Okay, so I thought, where do I start really? And I thought it might be helpful for us to do a very quick, one on type 1 diabetes, just as our kind of starting point. Now, I know a lot of you will kind of know what type 1 diabetes is and how it affects, what's going on there, how it affects body. But I thought it might be interesting to just watch this YouTube clip because it really does pull it all together quite succinctly. But it's also speaking directly to patients, so thinking about somebody who's maybe newly diagnosed with diabetes, and maybe if they came across this explanation of what type 1 diabetes is, and they are kind of relating it to some of their experiences, it's maybe just a nice perspective on how to hear that information in a different form. So I am going to share that with you now. I probably need to just pause this bit to put the YouTube one on. Sorry about that. Okay, so just 2 minutes.
About 10% of people with diabetes have type 1. It's got nothing to do with diet or lifestyle, it just happens. When you have type 1 diabetes, your body attacks the insulin-producing cells in your pancreas, so you can't produce any insulin at all. And we all need insulin to live. It does an essential job. It allows the glucose in our blood to enter our cells and fuel our bodies. When you have type 1 diabetes, your body still breaks down the carbohydrate from food and drink and turns it into glucose. But when the glucose enters your bloodstream, there's no insulin to allow it into your body's cells. More and more glucose then builds up in your bloodstream. So what does this mean? Well, before diagnosis, your body tries to get rid of the glucose through your kidneys, and that makes you wee a lot. Weeing so much leads to another symptom of diabetes, extreme thirst. Because glucose can't enter your cells to give you energy, you'll feel incredibly tired. To try and get energy, the body breaks down fat stores to provide fuel. That's why people often lose weight before discovering they've got type 1 diabetes. These symptoms tend to come on quickly, over just a few days or weeks. Anyone who has these symptoms should see a doctor as soon as possible. If you've got type 1 diabetes, you get insulin into your body by injecting it or using a pump which delivers a constant supply into you. You'll also need to check that your blood glucose levels are not too low or too high by using a blood glucose testing device several times a day. When you start taking insulin, you'll begin to feel better and your blood glucose levels will go down. This is important because over a long period of time, high glucose levels in your blood can seriously damage your heart, your eyes, your feet, and your kidneys. These are known as the complications of diabetes. But with the right treatment and care, the long-term effects of diabetes and high glucose levels can be managed. You can find out how we can help you manage your diabetes on our website. We're still not sure why some people get type 1 diabetes and others don't, or why the immune system of someone with type 1 attacks the cells that produce insulin. But our researchers are learning more and more about type 1 diabetes, so we can develop new treatments and one day find a cure.
Okay. So have I managed to take, oh, sorry. Sorry, I do apologise. I thought I do apologise. I thought I'd switched that off. Okay, so I'm going to just go back to. It's not allowing me to share my new screen. I don't know, Katie, if
I'll stop you as a host and then remake
if anything else can be done about it. I don't know what I'm doing.
Right, if you try it again now, it should give you the option. Yeah, that's on now.
Is that okay?
Yeah.
Okay, thank you so much. Sorry about that. So just to just thinking about that bit of information, I mean, one of the first things that people notice when they have a diagnosis of diabetes is that they lose weight alongside some of those early symptoms that they might see. And we'll come back to that because it's quite an important experience that a lot of people have been through that can influence things later as well. So we'll kind of come back to that a little bit more. So like Katie said in the introduction, we know that eating disorders are more prevalent in people with type 1 diabetes. Eating disorders affecting about 20% of females who have diabetes. And most commonly, then difficulties are going to take the form of disturbed eating behaviours, and that's going to cover quite a lot of the population who have diabetes. But what we're going to explore is that young people with type 1 diabetes don't just present with the range of eating disorders that we probably are all aware of and know about. There's kind of the extra complication that can come with the misuse of their insulin as a way of losing weight. And it's estimated that around 4 in 10, so 40% of the women aged 15 to 30 purposely take less insulin to lose weight. And it's important to not forget about young men as well. Around 1 out of 10 of them will purposely miss insulin on purpose as a way of trying to lose weight. Men with diabetes are more worried about their weight than men who don't have diabetes. So thinking about how do these eating difficulties, weight concerns, insulin and body image issues develop for people with type 1 diabetes. And there's a combination of physical, social and emotional factors that are kind of at play there. So if we think just about having type 1 diabetes in itself affects weight, we learned about one of the early signs of diabetes is that weight loss prior to diagnosis. And then lots of people, once they start on the insulin, will gain that weight. So there's an experience of gaining weight over a short period of time. So there's not only that experience of weight loss, which might have come with maybe comments from people, you look great, what's your secret, you know, these kind of comments that people get. People might have enjoyed some of that as well, comments that have happened. It might not necessarily have been all anxiety about what's going on, why am I losing weight. There might be some positive aspects to that for them, which we need to acknowledge. And then with the weight gain, equally, there might have been some emotional connection with that experience of gaining weight that might have been very difficult for them. And it gives them that awareness of the link between weight and insulin, which they might not have been aware of before. It's not something that people regularly kind of in the lay population will think about or know about, that importance of insulin being present to be able to maintain or gain weight. It can be more difficult to maintain a healthy weight when you have type 1 diabetes as well. Often things like having to eat regardless of whether you're hungry or whether it's meal times as a way of managing your diabetes. Lots of people will need to use glucose or snacks to kind of maintain their blood glucose levels. So that kind of brings into the picture lots of additional difficulties that people might need to kind of manage or juggle. There's a focus on weight every time, you know, our young people come to clinic. Every time they come to clinic, they are weighed and their weight is mentioned or discussed. There's a need for them to read carefully food labels, to check how much carbohydrate is in the food that they're eating. They may even be looking at the protein and fat content to think about the impact that will have on their blood glucose levels as well, which I don't know if we automatically think about when we're thinking about managed diabetes, but we do know that different fat and protein content also has an impact on blood glucose levels. So they really have to go into the detail and put a little picture there of that food packet, you know, bit of information that is there on food, and that might be something that maybe people look at, maybe people don't even consider it and look at it in their normal day-to-day life, but suddenly we're asking and training children from a very young age to be aware of the content, nutritional content of their food, and to be making decisions about it, much more so than we would children you know, who don't have type 1 diabetes. We wouldn't be encouraging them to examine closely those food labels. So it brings with it as well diabetes, quite a lot of parental anxiety, and I'm throwing that in there because, as well as thinking about young people, when you're dealing with an adult who has type 1 diabetes, they've often been diagnosed as a child, and they've experienced that system of being in a family where parents are maybe kind of concerned about their child's eating or the child's diabetes, and maybe have kind of ways of managing meal times. If you, for example, imagine yourself as a parent of a young child with type 1 diabetes, and you've given them their insulin, and they suddenly say, I'm not eating that, it's very difficult to say, well, that's the only thing on offer today. That might be your normal parenting style, to say, well, if you're not having that, that's what you're having today, and you go hungry, kind of thing. It's not that easy for parents to follow maybe some of their more natural parenting styles, because they suddenly have a child who's had insulin and needs something to eat. So, okay, have a biscuit, have anything, just to make sure you don't have a hypo. So it can change a lot in terms of family dynamics, family boundaries and things like that. For young people and people who are diagnosed with type 1 diabetes, there can be an element of a lack of control over their life when they have a diagnosis and they have a health condition to contend with. There is sometimes a feeling of feeling vulnerable, or feeling that they lack control over their body or their life. It's very easy to feel like you're failing when you're managing type 1 diabetes. It's kind of helpful that there's these targets for your blood glucose levels, so you know what you're aiming for. But at the same time, what happens when you don't reach those targets day in, day out? Easy for you to get into a cycle of feeling like a failure, feeling shame about your diabetes management. And then that feeling of difference as well can be very important, especially when we're thinking about the impact that has on things like self-esteem and self-identity as well. And I think when you consider all these things that are going on for young people, on top of the usual challenges that adolescents are kind of facing, it starts to be understandable why these young people are possibly at more risk of developing an eating disorder. So when we're thinking about young people and adults with eating disorders and type 1 diabetes, they may take the form of what we usually consider an eating disorder with restricted eating. You might see an anorexia presentation, equally binge eating, or that being there alongside vomiting, maybe excessive exercises. But the one that I think poses this unique challenge is the insulin omission. So that's where I'm going to focus a little bit of my talk today. I will bring in some of the others because there is kind of still the complications, but it's insulin omission that really presents quite a tricky kind of area for us to kind of get our heads around and think about, particularly about management as well. So if we're thinking about that insulin omission form of an eating disorder, then often you will have heard it referred to as diabulimia, which still really isn't recognised as a kind of medical term, but is a media coined term. And it does refer to those people who are purposefully restricting their insulin in order to lose weight. One thing I realised when I got to the end of designing this presentation was that I usually include quite a bit more patient as the expert. I haven't got as much as that as I'd like to, and I'm out of time in terms of putting anything like that in, but there are programs, and this one was on the BBC quite recently, which I thought was a really helpful kind of insight, and it obviously speaks to people directly who are kind of juggling and managing this condition, and I thought that that might be a way to direct you to something that is a lot more patient focused in terms of hearing directly from people themselves. So yeah, I urge you to, you know, YouTube that, and or get it on the iPlayer, maybe it'll still be available. Okay, so if we think about insulin emission and how that kind of presentation kind of develops, really. Diabetes is a chronic condition. It, you know, produce a lot of frustration with targets, and people are susceptible to burnout with it. You can feel especially uncontrolled. Managing their diabetes, people missing the odd bit of insulin with their food is probably quite normal and common. Sometimes it's kind of with snacks, or it might be forgetting it or something. Really, if you think about how many times a day people are required to do something, and there might be a kind of spike in the blood glucose levels as a result of missing insulin, but it might be something that people kind of get back on top of quite quickly. They correct for that and manage it okay, but they might have episodes of doing that more or less as well. Actually, it might not be, purpose might not be to lose weight, but they might notice that actually when I'm forgetting it more often, oh, look what's happening, I'm losing weight. And again, that connection with insulin is made. So it might not be the initial goal. And they might not experience physical symptoms as well of DKA. They might just notice that their blood glucose levels are a bit higher, and actually they stay a little bit higher for a while, and there's no kind of immediate consequence to that when it's happening here and there. It might escalate quite quickly though, because I think once that connection has been made, and that decision has been made that actually I would like to lose weight, it's something that can be, it's not an extra act that needs to happen, it's one that needs to be admitted. So it can happen and escalate quite quickly. It's also a bit of a hidden eating disorder if you think about it, the insulin emission, because these young people can eat what looks like their eating patterns might not actually change at all. They might continue to, you know, have their donut after their dinner. They don't seem to be worried about that. They don't seem to be refusing food at meal times. They may be still eating their packed lunch. They may be still going, you know, Alder, still going out for a drink with their friend, eating out with their friends. But if they're not taking their insulin, they won't be getting the carbohydrate, the glucose from that food that they're eating, and they will begin to lose weight as a result of that. So it almost might look very normal from an eating pattern point of view, but there's this hidden action that's going on behind the scenes which is causing weight loss. And very quickly that relationship and that connection, just where insulin for some people begins to very quickly just feel like it equals fat or it equals weight gain, and they have that relationship with insulin that maybe we see for other young people with eating disorders that they have with food. Whereas if I eat that one bit of food, I'm going to gain weight or I'm going to get fat. They might start to think of their insulin in that way. So the important things for professionals is to be able to look out for this hidden, you know, eating disorder. Really, it can be hard to spot. Like I say, maybe no change in eating patterns. So what are you going to see? You might see the significant weight fluctuations or loss. You're going to see the very poorly controlled blood glucose levels and the repeated high blood glucose levels with the high HbA1c, which is the measurement of a blood glucose level over a period of about 3 months. We can get that reading, and that gives you an indication of where people's blood glucose levels has been. They might have frequent episodes of DKA. that maybe sometimes are bringing them into hospital. So it's important to notice if somebody is coming in DKA repeatedly. They might be saying, you know, don't know why it happened, but actually what might be happening is a desire to lose weight. There might be some inaccuracies in their blood glucose monitoring that don't really add up. So some of the young people I've seen who some of them used to keep a paper diary. This is a little while ago now. It might be on their blood glucose checks. They can look like they're getting very accurate blood or close to target blood glucose levels, but then their HbA1c is kind of really quite different, and so there might be inaccuracies and manipulation of some of the kind of recordings as well. Secrecy about that diabetes management, that maybe not sharing information at all about what their blood glucose levels are, the fear of that being found out, that there's there might be a fear of low blood glucose levels as well. And actually I think that should say fear of high blood glucose levels, because I think that's probably what you would see more. That, oh no, fear of low, sorry. Fear of low blood glucose levels, because what they're wanting to see is the high ones, because they know that that means that they're likely to be losing weight, and the low ones to them mean that they've got more insulin on board, and therefore that equals fat. So they might have some strict food rules still, even around their the diet that they are eating. They might have difficulties when they're asked to be weighed or talking about weight. They might start to share some body image concerns with you, and there might be low mood and anxiety accompanying some of those difficulties. I have got a YouTube clip there, which I think is kind of detailing more of the warning signs. I'm not going to do that because I do want to leave the time for questions at the end. So I think in terms of thinking about the screening questions that you might be able to use once you've noticed some of these warning signs, there's a very simple version of a screening questionnaire called the SCOFF, which is kind of used by GPs in order to enable them to think about just some simple questions that they might ask somebody who presents with them, and they're thinking about whether they need further assessment for an eating disorder. So kind of just covering those areas. Now this might be the same for somebody who you're seeing who has type 1 diabetes, because like we've said, they may present with some of the more typical eating disordered behaviour. The way I would use this is I would weave these questions into more of a kind of conversation with somebody. I think you're not going to always get the responses that you need if you sit there with a very formalized way of firing questions at somebody. So I wouldn't necessarily think that whipping out a sheet of paper to do some ticks on would produce the answers you need to really find out if this person needs to go. But weaving into the conversation, you know, exploring, you know, have you ever made yourself sick because you feel so full, or do you feel guilty about or ashamed about what you've eaten? You know, exploring some of these areas with people is really what I think this can help you to think about areas that you want to know more about. The one that's added for to make it into the MSCOF is the last question, which is where thinking about taking insulin to treat your diabetes, do you ever take less insulin than you should? And I, again, carefully think about when in a conversation would be a helpful point to ask them. I sometimes phrase it to say, is it more difficult to take insulin sometimes? And that sometimes opens up more of a conversation, because you're not saying it black and white that do you not take your insulin then because you want to lose weight. It's more like, does that sometimes feel more difficult? Is it more of a struggle to take your insulin at those times? Might be a way of a young person or a person feeling able to start to share some of the things that make it harder for them to regularly take insulin. So when for people who omit insulin, there are you know, the consequences of that, which we need to consider. Obviously, the one that they're looking for might be the weight loss, but there are some other important ones that need to be considered. There's DKA, which obviously was mentioned in the video, and we'll have a look at in a bit more detail. Long-term consequences of diabetes, again, those were included in the video very briefly. But then the most important one that we need to consider is how dangerous this condition is, that death can result of people who are not taking insulin. And sometimes it might be with the purpose of losing weight, but it can result in that serious consequence of death. They're more at triple the risk of DKA and nearly 6-fold increase of death compared with their peers without eating disorders. So I think it's important to think about how much more dangerous it is to have type 1 diabetes and an eating disorder than an eating disorder on its own. So if we think about DKA, that's a serious problem in itself, and it's caused by lack of insulin in the body. The body starts to break down fat for energy, and ketones are harmful substances that are released into the body just as the fat gets broken down. And then this eventually can be life-threatening if not spotted and treated quickly. So the symptoms of DKA will be very similar to those symptoms that that people present with when they are initially diagnosed with diabetes. So needing to pee more than usual, being very thirsty, feeling sick, stomach pain, that kind of smell that can be on people's breath. Their breathing can be affected, feeling very tired and lethargic, sleepy, and they may be confused or even passing out as well. So we do have young people who sometimes come to clinic, and maybe they're coming to clinic because they have been really struggling, but they might be presenting with some of these symptoms, and they might have, like I say, in terms of these repeated admissions. And I think if we aren't clear with a young person who's been admitted about the reason for their DKA admission, and especially if we're seeing them arrive in more than once, then we kind of really need to understand that a little bit more. And sometimes that will be a conversation with myself around what might be happening. Now, it might not be an eating disorder. There might be other things going on at home. There might be low mood and depression. There might be school-related issues. There might be issues at home. You know, there can be a variety of issues. Eating disorders is only one of the things that we would be kind of screening for and checking out for. Some of the long-term consequences that again will be prevalent, and therefore people with diabetes, when their blood glucose levels are kind of consistently been difficult for them to manage. High blood glucose causes damage to the blood vessels, and that can result in things like retinopathy, macular edema. Nerve fibers are particularly vulnerable to those prolonged periods of high blood sugar. So things like peripheral neuropathy, gastroparesis, chronic diarrhea and constipation, other organ damage as well, the kidneys, liver and heart. And again, you know, those ultimately becoming fatal for people with coma, stroke and death being possibilities there. So thinking about that then, diabulimia being this kind of most dangerous of all eating disorders really, and that being quite an important message to kind of understand and hear, especially when we're thinking about how we help people with this kind of comorbid condition. One of the real challenges is the difference in approach between eating disorders and diabetes services. I think, you know, the NICE guidelines really recognise this contradictory advice that might be happening, and I think this is the bit that makes it represent that unique challenge. We've got two kind of competing conditions that are both very serious and both really need attention and management, but the way in which to treat and manage them is quite, there's contention that, you know, there's conflict there. So managing that is really important. So if we think about those tensions, one of the things that diabetes clinics might tend to kind of focus on is the importance of getting as much of this right as you can, and very quickly you can see some young people and families taking on that kind of important message of being able to manage this as well as possible. They're given quite clear kind of standards almost that they are aiming for, so that we can minimize those risks of any long-term complications. And the better you get, the more likely you are to reduce your risks of these things happening. So we're always helping people and families strive for as best management as they can get. So you can imagine somebody maybe who already has some of those perfectionist tendencies, or really wants to please, or really just wants to do an excellent job of looking after themselves, is that they're trying so hard to manage their blood glucose testing, optimal timing of insulin, thinking about their meals, planning their exercise really carefully in order to optimize their blood glucose levels. On the other side of that, we know that when it comes to eating disorders, perfectionism and that rigidity is exactly the thing that kind of maintains some of those eating disorder cycles. So that can be a real contention there. We teach lots of rules about managing food, thinking about nutritional content, right down to a lot of detail, really. Like I said, even now recognizing the impact that protein and fats can have on blood glucose levels, not just carbohydrate. So we really are wanting people to become experts in food knowledge, really. And that can be a kind of real challenge, because when it comes to eating disorders, those rigid rules around food and eating are kind of seen as problematic when it comes to encouraging a little bit more of a flexible and relaxed approach to a diet, plan eating, and those two things again can be very difficult to manage. We encourage quite a lot of autonomy, especially as they are kind of, you know, more taking a bit more responsibility, managing their own blood glucose levels. They have their insulin available at the touch of a button. Lots of young people become very adept at managing their diabetes, often because a lot of it relies on technology, and they can quite easily cut their parents out of the loop with how quick they are at managing their blood glucose testing or their insulin bolusing. So it can all be done quite quickly and almost without parents being aware and seeing it. And that can become problematic when you're then trying to manage it in the context of an eating disorder, where young people have been kind of almost encouraged to get on and do it themselves, that suddenly the need for some supervision or some support around insulin administration can become quite challenging, really. So those are just some of the conflicts and tensions that appear. So what we're aiming for a lot of the time when we are thinking about supporting and managing people with type 1 diabetes and eating disorders is there some middle ground? Is there some way we can work together on the eating disorder and on the type 1 diabetes to maintain some safety and to think about making some changes that kind of take account of both of those positions, really. So I have put those in full, but really the message that comes from the NICE guidelines is how important it is to work closely together. Because if we don't work closely together, we're just pulling into opposite directions, really. So things like agreeing who's responsible for monitoring physical health is really important. We've said about how, you know, dangerous it can be. So the monitoring of physical health, we need to decide, is that going to be done by the diabetes team? Is that going to be done by the eating disorders team? What we found in Alder, we do have an eating disorders team, so it's part of the hospital. So communication can be quite easy. You know, that we're copied, you know, we can access each other's notes really easily. It's a bit more difficult when you've maybe got an eating disorders service that's in a different trust to the hospital service. communication can be difficult. It also means that we can, because we've got an eating disorders service in the hospital that has kind of a linked nurses and doctors in the hospital, we can decide whether which team it makes the most sense to do certain aspects of the monitoring. So it might be that the diabetes team is obviously keeping an eye on some aspects of the physical health, but then there might be other parts of the monitoring that is done by the team. I noticed that once when I had a young person who had type 1 diabetes and an eating disorder, they came through to see me, but it wasn't until they went to the eating disorder service and was seen there that they sent for certain blood tests to be done. They hadn't been done by the diabetes team, because I think they were approaching it much more from a diabetes point of view, whereas the eating disorders team were becoming a bit concerned about our weight loss and went forward with different blood tests, which I think showed the importance of that communication and need to work together. And then when it comes to treatment as well, thinking about gradual changes is really important when, you know, thinking about the amount of carbohydrate in their diet. It might be that the conversations between the two teams need to happen about, well, how much insulin do they need to have? Well, how much carbohydrate, how much carbohydrate would they, you know, tolerate at this time, and does that change how we kind of approach us trying to get back to normal blood glucose levels? Would we maybe aim for a halfway point first so that we can slowly work towards something? Might be really important. Thinking about psychoeducation as well, not just about how the impact of omitting insulin might have on their body and their health, but also about the psychological side of their bodies not getting what they need, you know, in terms of the cognitive impact as well. So there's often quite a lot of information that is helpful to share with people at the right time in order for them to make decisions about their health and their treatment. So when it comes to treatments, like I say, the joint working is the kind of main issue. We do sometimes need to take a harm reduction approach. So there might be some education needed. There might be some contracting as well in terms of what they're able to achieve in terms of, from a behavioural point of view, in terms of eating maybe a minimum amount of carbohydrate in a day. And that's where kind of family support as well is quite often needed in order to help them manage that and achieve that. So quite often a CBT approach can be taken, but as long as you're considering those two important aspects of their presentation. The charity DUED is a helpful one to access, but that also has support for professionals as well who are working in this field. So that's got quite a lot of resources. They also do training as well for people, so we'll come out to services to do some of that training, specifically looking at diabetes with eating disorders, and that can be really helpful to know about. So the key points, the first bit is the awareness bit, and it's going back to what I said about it being a hidden thing. So, you know, you guys coming to learn about it, to hear about it, to bring it to the front of your mind is the kind of number one step, really. So you know what's, you know, what might be happening, and you can be aware that, you know, some of those warning signs might mean that there's kind of some concerns about weight and shape and body image, alongside some of these kind of behavioural things that you might be seeing. But not only having that awareness, having the skills to be able to open up conversations about weight and body image in a kind of non-judgmental way, to just explore some of those things with people is the next most important thing. Because people, I always say it's quite interesting, because when I was speaking to my eating disorders colleagues when we first started working more closely together. We were talking about the differences in presentation, and I was saying, well, in some ways, all the people you see have been referred by their GP or by another health professional because they've presented with something very clearly eating disordered related. Do you know what I mean? So lots of people, and then they're attending an eating disorder service to talk about those issues. So in a way, they've kind of skipped a whole aspect of what we might have to deal with when we're seeing a young person in a clinic environment, because some of those conversations have already been had with their GP. So we are kind of starting from a few steps back from where the eating disorders colleagues are. You know, often this is not something that has been spoken about. It's sometimes not even something parents are aware of, that their children have because they've not seen the change in the eating patterns. They may be thinking they're just not doing what we're telling them to do with their diabetes, and now look at them, they're losing weight. That might be the only information that a parent maybe is coming with. Maybe the young person themselves is thinking they've got no idea what I'm doing. I mean, I did read about one person who said, when I realized that I could lose weight without changing my eating by just omitting insulin, I suddenly thought, I've got a secret weapon here. I've got something that nobody is going to know about, and I can use to achieve something that I think would, you know, potentially help me. And so it is from that point that you're sometimes starting from when you are at first talking to somebody who you think maybe there are body image concerns that are driving some of this difficulty with managing their diabetes and blood glucose levels. So having conversations about body image, about weight regularly means that if these issues start to occur, you've already kind of got some of that conversation happening as well. And there needs to be the screening. So once you've had those kind of conversations, are you able to kind of think of them in a little bit more of a screening way? And that's where the MSCOF can come in handy. Like, have I thought about, have I talked to them about different ways that they might be trying to manage their weight, or when they overeat, what does that make them feel like wanting to do? And I think sometimes a key part of having those conversations is to not necessarily to normalize it a little bit, or to say, you know, you're kind of aware that those things happen for other young people, and so that it's okay to talk about. Yeah, so you might say, well, you're telling me that you have a lot of difficulties with how you are thinking about yourself in relation to your weight, and sometimes young people, when they have those kind of concerns, they try to do things to manage their weight in ways that maybe aren't as helpful, and they might end up and asking questions outright, like, have you ever made yourself sick, and things like that. Is okay to ask those things, because a lot of the time we can become a little bit worried about raising things. Am I going to give people ideas? I mean, the evidence shows that actually it's much less likely to prompt a behaviour than it is to enable somebody to talk about it and address it in a different way. So it is always helpful to have those open conversations. I suppose the next point after that is that how do you then make a referral to the right services? And I think a lot of the time young people have been open, when I've worked with them, have been open to the eating disorder service being involved once they've understood that it's important for us to joint work these things, that we're not just seeing it as an eating disorder and being passed over to that service, that we are kind of really aware of the role that diabetes plays in this picture as well. And then when it comes to treatment, like I've said, the options that are there are kind of the similar options that are there for those kind of issues anyway, but they just have to be done in conjunction with each other. And then the bit, and I probably got this totally upside down, because I think the most important thing is that we help people from the very beginning of their diabetes journey to develop a healthy relationship with food, their body and insulin. You know, right at the beginning of the talk, I talked to you about all the things that happen to people that kind of set up the scene for people to have some of these difficulties. So from day one and diagnosis, understanding that what we kind of say, the information that we give people around kind of maybe how their weight has changed, what's likely to happen to their weight. One person said to me, I didn't realize that when I didn't realize that it was normal to gain weight once I'd started taking insulin. So I just saw my weight increase and I just thought it was going to carry on increasing. I didn't realize that I would get back to maybe my healthy body weight again, and that I would be able to then maintain that by looking after myself, my diabetes, and maintain. They just thought that they could just see their weight increasing massively. And so actually that's really important to know then. Can we talk to people around the time of diagnosis about what to expect and to reassure them about that? And then, you know, from day one, then we're opening up the conversations as well. That might help them to develop that healthy relationship with food. You know, can we have conversations that acknowledge that they don't have to be perfect when it comes to managing and understanding every single little bit of nutritional content around food, that things don't have to be perfect all the time with regard to their diabetes management. These things can be really important. So there's a little summary on YouTube, which again is, I think it was from the Diabetes UK website, that I thought, oh, that's kind of really summarising everything that I've spoken about today. I won't play it because hopefully I've been through it in a little bit more detail than is on there. But if you are trying to let somebody know about it, or you want to pass it on, or you want to have a little recap of it, I can, I think I'm just going to double check I can just add the link to that instead of the, but I think it's the Diabetes UK one. If you just give me a second, it'll start playing, I'll check. Yeah, I think it's accessible from Diabetes UK, but I'll get the YouTube link so that that's added to that as well. And that's the end of my talk, because I do want to leave those few minutes if anyone's got any questions. I'm sorry about all the text stuff at the beginning. It's a while since I've used Zoom. It's all Teams and yeah.
Well, thank you so much for that talk.
And we've got anyway. Thank you.
Thank you so much for that talk. I think it was really interesting to kind of hear about the different perspectives and also kind of consider how we have those conversations. Because I think, as you say, sometimes you can be sort of cautious of having them. So kind of having them from the beginning and kind of threading them in, as you say, I think will make a really big difference.
That's it, because it's just acknowledging that it's okay to have, you know, thoughts and feelings about what's happening to your weight, and that you need to be able to discuss those with your healthcare professionals, because they are part of living with diabetes, really. You know, just, you know, if weight needs to be talked, you know, asking how does it feel talking about weight. You know, we've kind of brought it up in clinic today, or you've just been weighed. How do you feel about it? And they will probably share with you, I hate talking about it. You know, well, why do you hate talking about it? It's something that has bothered you for a long time. And there you are, you're in the conversation with them about weight in a very non-judgmental way. And they will probably tell you what their kind of worries are about their weight. You probably don't have to go into teacher mode of I need to warn them about all the risks of them losing weight or gaining weight in this situation. They'll probably be able to verbalize them to you, really, if you ask some of those nice communication skills, open-ended questions where you're just saying, you know, what are your thoughts about that? How do you feel about that? And they will really appreciate those being asked that. Yeah,
definitely. I think that's really, really important to consider as well, to kind of move away just from focusing on the medical kind of side of things. So if anyone does have any questions, feel free to put them in the chat, or you can unmute yourself and ask them as well.
Could I ask a quick question, Katie and Dr. Simmons?
Yeah, sure.
So thank you so much, Dr. Simmons. Firstly, that was really fascinating. I guess I was wondering about your experience with, well, working with young people and parents. Like, do you get much resistance from parents, or how do you sort of tailor your approach and make it as non-blaming as you possibly can to look at the whole family unit?
Yeah.
If you have any tips for that.
Really interesting. I think it can be challenging because a lot of what we might be seeing is the impact of how parents' responses or demands on perfection. You might kind of pick up there's a sense here from this family and the way that they work, and it's really important to be able to engage the parents and the young person, and you're not going to do that if you go in with a kind of blaming attitude. And often where I come from is a lot of parents' behaviors are from a point of kind of love and anxiety a lot of the time. They really want to be healthy and able to enjoy life, but their priorities are maybe to kind of, so that might have then promoted quite a perfectionistic kind of approach within the family to that. So I always think, and when I'm talking to young people about kind of parents' involvement, it's often anxiety that is the biggest hurdle. And as soon as you recognize that, I think a lot of parents are open to saying, yeah, I do worry about my child. How can you not if you're a parent? And so therefore you can start to have a conversation with them about how that, is kind of, interfering or making it difficult. I use those kind of words really, because it's not that people don't want to support their children in the best way. It's that it's hard. It's a challenge when you've got these kind of competing things to be thinking about. The biggest thing that we probably have with this particular situation is, though, that parents might not be thinking eating disorder at all. They are thinking, my child's being a nightmare, or my child's, just not doing what they're told with their diabetes, or they're rebelling, or they're, they're just, having a difficult time with something else. They might not necessarily see their diabetes disengagement from diabetes management as being to do with weight or shape, if they've not had those conversations with their child. So that's sometimes the tricky conversation, that you can't really dive in and say, right, we think this is eating disorder and we're going to refer you to the team. It's kind of you need to go in, engage them in the conversation. Often, you might share with them if they are completely not in that area at all. Sometimes you get the sense that parents might be thinking it as well. So therefore, one of those questions like, what do you think might be going on here that makes it difficult for her to take all her insulin? And then they might start to share some of their worries about it. But if they're not there at all, it might be that you kind of, again, I use the way of talking of saying, it's not unusual for us to see girls with diabetes having worries about their weight and shape, and that affecting their ability to take all the insulin that they probably need. Is that something you've ever considered, or what I mean? So you kind of engage parents, but that again is a non-blaming way to say it, because you're saying this happens, and it's okay to talk about it. We want to help with it.
Thank you for that.
And we've just got one quick question to end with from Kate. So, would the Mental Health Act ever need to be considered for someone who has type 1 diabetes and an eating disorder and is close to the idea of taking insulin? For example, if they're coming in regularly with serious DKA and don't want to take it, in the same way that it might be used for someone with anorexia and an extremely low BMI.
Yeah, I think, and you brought up an interesting point as well. I think the answer to my dream, but yes, that could happen in very much the same way. In fact, we might need to consider it sooner than you would, because of that combination of serious risks to their health and potentially death. if we're not able to treat them. And that's the bit that it kind of brought up really. I've lost it. I forgot what I was going to say, because you brought up another issue that I was going to say. It'll come back to me, but it's definitely because we need basically that was it. We need to actually have a threshold, because when I first started working with the eating disorder service, I found that they obviously make a lot of their risk assessment based on weight, just automatically, whereas that's not probably our biggest the DKA. It can happen quickly. We can see that in a week you could go from how quick it would happen. If you completely stopped taking your insulin and didn't take anything at all, health would go down dramatically so quickly in a way that you couldn't do it with weight loss. So in fact, we have to have slightly higher thresholds, lower thresholds, a higher threshold for responding. We need to respond quicker. So that was a really important learning curve for us with the eating disorders service, in terms of how do we communicate about our risk assessment. I mean, it wasn't it was medical risk assessment, but yeah, so good point.